is the very first. Thank you. This is the very first in a series of webinars that we will be hosting every 2 weeks for the next couple of months. And this is the End Malaria webinar series. We all know that the world is marking the World Malaria Day today, mainly because malaria remains a major challenge on the continent. The numbers, I won't even go into them. The numbers are always depressing, but we know that progress has stagnated over the last several years. We're not seeing much progress on the continent in terms of reducing malaria, and even the whole vision of elimination. We still have a long way to go. And so today we are going to be talking about what will it take really to significantly reduce malaria and eliminate this disease on the continent. We know that this disease has been eliminated elsewhere several decades ago, but it remains a major killer on the continent. And so the webinar today is a kickstart, I would say, in the conversation we're going to be having in the next couple of weeks through this webinar series. And the webinar is structured in 2 main sessions. So we have a session where there will be a keynote address, just kind of laying the ground in terms of where we are, the persisting challenges, but also how does the pathway to elimination look like? We know that there are countries and some on the continent that have eliminated malaria. So we're also going to be looking at that. What can we learn from those countries? So that countries that are still bearing the huge burden of this disease can draw some lessons from there. But also, what are the opportunities, for development of new tools and just changing the way we invest and the way we work to ensure that we move closer to eliminating this disease. So we'll be starting off with a keynote address, and then we'll move into a panel discussion. And we are so honored today to have colleagues, experts in this area from across the region. We have, of course, Professor Richard Nkabana from AFIDEP will be making the keynote, and then we have 4 leaders from different parts of the continent. We have Honorable Batua from Uganda. He's a key malaria champion, and he leads the Uganda Forum on Malaria, who will be on the panel. We have Dr. Fredros Okumu, Director of Science at Ifakara, again, a very well-known academic and a big champion for ending malaria. We have Dr. Susan Imbahale, who is a senior lecturer at Technical University in Kenya, a malaria expert as well. And we have Mr. Joseph Shija, who is the head of Zanzibar Malaria Elimination Program. And we know Zanzibar has made notable progress as well towards elimination. So we'll be learning quite a lot from there. So in the interest of time, I would like to get us started. I see on the agenda, we have a Zoom poll. Colleague from AFIDEP, if you can clarify what that is that something we need to do, or should I move on to inviting Richard to make the keynote address?
Please move on to Richard to making the keynote address. We would have instead a feedback form at the end of the program. Thank you.
Okay, fantastic. Thank you so much. So I'll take that opportunity to then invite Richard, who will be giving a keynote address for about 10-15 minutes, and then that will open us up into the panel discussion where we'll have a Q&A. And of course, encouraging colleagues who are here as Richard presents, and even as the panel conversation, which will go on for a few minutes before we open up for everybody, please feel very free to put your questions or comments on the chat. Again, we welcome you to introduce yourself, your name, the institution you're coming from on the chat, just so that we have some interaction going on, but we also get to know who's here today. So thank you so much. Richard, if you're ready, please feel free to go ahead to put up your slide. I think I'll just mention, maybe some people are here who are hearing about AFIDEP for the first time. We are a research and policy institute with our headquarters in Lilongwe in Malawi and an office in Nairobi, Kenya. We work across the continent, and our main driving point is making evidence matter in development issues. And so we work very closely with governments, with parliaments, with development actors to develop and nurture a culture of evidence using decision making. That is AFIDEP briefly, just in case you're joining for the first time and you don't know much about AFIDEP. But Richard, welcome. I don't see your slides up. I know you have some slides, so please go ahead. Thank you.
Good afternoon, everyone. My name is Richard Mkabana. I work for AFIDEP as a senior research and policy analyst, and I'm the director of the Health Technologies Platform. I'm honored today to give this presentation on the World's Malaria Day 2023, and I would like to discuss with you or to talk to you about what it will take to eliminate malaria in Africa. I would like to begin with some statistics. How much malaria do we have in Africa? So Africa, I would say, is the home of malaria. Most of the malaria cases that are seen in the world come from Africa. And also the number of people dying from malaria are highest in Africa. In 2021, of all the malaria cases reported globally, 96% came from Africa. 95% came from Africa. And of all the people that died of the disease, 96% came from Africa. A few countries in Africa are at the top of the list of countries that contribute to the highest number of cases and deaths from the disease. Nigeria is at the top. The Democratic Republic of Congo, Uganda, Mozambique, Burkina Faso, Mali, and Ghana. Recently, there is a threat that has come on board. This is a mosquito known as Anopheles stephensii, a very good transmitter for the disease, reaching us through the Horn of Africa from the Arabian Peninsula and the Indian subcontinent. In Africa, a few countries have managed to eliminate malaria. And I would like to mention what these countries are and what we could borrow from their successes. Usually, by WHO definition, if a country reports 0 indigenous malaria cases for 3 consecutive years, you are allowed, you as a country, to approach WHO and seek for or apply for WHO certification of malaria-free status. And here we have a list of countries that have done just that and got that status. The most recent country to get this status, the malaria-free status, is Algeria. That came very recently, that is 2019. There we saw the last indigenous case of malaria in 2013. Number 2 is Lesotho, a small country within South Africa. When I have searched the internet, I've seen that there's no malaria in that country. And even from historical reports, I did not get anything that showed that this country has got any malaria. Mauritius is number 3, and it got certification long time ago in 1973. Its biggest malaria burden came in 1867, so many years ago. At that time, 43,000 people died of the disease out of 330 people in the island. Then number 4 is an island that is off the east coast of Africa. We call it Reunion in English. In French, we call it La Réunion. La Réunion got this malaria-free status in 1979, and the last malaria case was seen in 1967. Seychelles, a very attractive tourist destination, has no Anopheles mosquitoes, neither does it have malaria. I have put Cape Verde on this list. It's not yet certified as malaria-free, but for the last 3 years, before 2021, this country recorded 0 indigenous malaria cases. And I know that Cape Verde has already applied for a malaria-free status. So maybe within this year, we will hear WHO announce that there is no indigenous malaria in Cape Verde. So let's look at Algeria. I'm picking at Algeria just as an example, so we know what it did and how it has come to be labeled malaria-free. Historically, there was a lot of malaria in Algeria. You might want to know that Algeria is the country where the malaria parasite was first identified in 1880 by the French physician Charles Laveran. So those of you who are meteorologists, you probably know the name Laveran. And then in the 1960s, Algeria probably had its biggest health challenge. And that big health challenge came from malaria. 80,000 cases were being reported every year in the 1960s. But more recently, in 2013, Algeria reported its last indigenous malaria case. Look at the graph on the right as I keep talking. So you'll see that since 2014, the indigenous malaria cases are zero up to 2018. That's the data that I have until right now. So in 2018, there was only one introduced malaria case in Algeria and also 1241 imported malaria cases. Which malaria parasites do we find in Algeria? Mainly Plasmodium falciparum and Plasmodium vivax. In Algeria, the southern part of it borders countries that are very endemic for malaria. Here we are talking about Mali and Niger. So a lot of control efforts went in the south after they were able to clear the disease in the north. There is also this Trans-Sahara highway that traverses Algeria from the south. A lot of people that came through that road brought in malaria. So exactly what did the government do to make sure that they were able to kill any mosquito and to treat any case of malaria in the country to eventually attain a malaria-free status? Number one, Algeria has excellent healthcare infrastructure. These extend even to remote areas of the country. And that means that it's easy to be reached. So what has the country do to prevent sustained transmission of malaria? So number one, they have a robust integrated surveillance system. People coming into the country from the south who might have malaria because they come from endemic countries will be reached by healthcare personnel very quickly. The healthcare personnel are also very well trained, and they have a rapid response system to get to people that come into the country who are suspected to have malaria. Algeria also does effective vector control. And when you look online, you'll see, for example, that they have a very robust indoor residual spraying system, which of course was very active to contribute to the malaria-free status. They do have universal health care. They have a rapid response system to outbreaks. And one of the main things they do is early diagnosis and treatment. If you go to Algeria today as a foreign person staying there, you'll get free medical cover. You'll be treated in the country, and they'll look for any disease and kill it. So here you see in the picture on the bottom right, the presidents of Algeria and Venezuela getting the malaria-free status certificate from the World Health Organization. Moving on, so what has Algeria done since they saw their last malaria case? They continued simply with the things I've mentioned, one of them being the free healthcare to everyone. They still do early diagnosis and treatment of malaria cases. They also are able to rapidly identify suspected cases. They also do vector surveillance. And of course, there is also effective oversight from the government. So government has got very big interest in controlling this disease or eliminating it in the country. So they have a continuous effort in order to keep indigenous malaria cases to zero. Okay. So what was the role of government in this success story? What did the government do? So number one, this effort was homegrown. Government agencies are the ones which are at the top of this effort. And those include the Ministry of Health, population and hospital reform. That, together with the National Institute of Public Health and the Pasteur Institute, were at the forefront of controlling the disease. So something homegrown has worked for Algeria. Besides that, the government put in a lot of financial support, and it continues to do so. And lastly, the government identified a strong technical partner in the name of WHO, so that they would get technical advice as they kept rolling out the control program. So this has come to happen in Algeria, but we don't want to assume that there were no challenges that the country could have incurred. These challenges actually apply across the African continent. So let's see what these are, and these are what other countries in Africa will need to do in order to be able to eliminate their malaria. So number one, there has become a big problem around the African continent that sometimes you take a drop of blood from a patient who actually has malaria parasites. You put that drop of blood on a rapid diagnostic kit and you don't see the disease. That is becoming a problem in some parts of the African continent. What you see here is a rapid diagnostic kit that has worked very well for malaria. And it has been actually one of those that are of choice for detecting the disease, and is starting to miss the parasites because of some mutation within the parasite. So if you want to do a program like Algeria's to do active surveillance, you might report no cases for the disease, yet some may have escaped the laboratorians. So failure of detection. Number two, we also have malaria parasites that cannot be killed with the commonly used antimalarial drugs. We see resistance rates of about 10% or failure rates of drugs of about 10% in countries like Burkina Faso, in Uganda, in Angola, in the DRC. We see these kind of things happening. And resistance, unfortunately, is also happening for the AL drugs, artemether lumefantrine, which is the drug of choice for treating malaria within the African continent. The alternative drugs like dihydroartemisinin, piperaquine, we also see resistance, especially in Burkina. So if you get malaria and you are unable to treat it, I think the next thing is to visit the man above and see if he'll have room for you. So number two, parasite resistance. And then number three, I would like to make this slide a bit bigger so that you can view something. Number three, there's a lot of resistance of mosquitoes to insecticides. Pardon me for a minute, I want to, yeah. So look at that map of Africa and you see how resistance is changing over time. That begins the year 2000 and it plays until 2019. So many, many red dots are coming on that map. A lot of areas in Africa now have the problem of insecticide resistance. Recently, WHO has put up new recommendations of what we can use on insecticide-treated nets. So there are two chemical combinations combining, for example, pyrethroid and chlorphenipar, a new molecule that is now very active against the mosquitoes. And also we can combine what we've been using on nets with something called pyriproxyfen, which just enhances the mosquito susceptibility to the pyrethroid. Please let me know if this slide has moved on your end. If it hasn't, let me see what I can do over here. Can you see the next level of funding? Thank you so much.
Yes.
Thank you so much. So there is also another problem of funding. You will notice that most African governments depend on foreign aid to fund their health programs. And this, for malaria, has had a gap, a funding gap. So look at 2019. the funding gap for malaria globally was shot by $2.6 billion in 2019. In 2020, it was shot by $3.5 billion, and in 2021 by $3.8 billion. I think something needs to be done at home, the way Algeria has done to eliminate and sustain elimination in the country. Then came the COVID-19. COVID-19 brought up a lot of interruptions in many healthcare systems around the continent. See here, for example, that in the year 2020, only 74% of all bed nets that were planned for distribution could be distributed. Another 26%, there were interruptions in the healthcare system that could not happen. The same also happened in the year 2021, where only 128 million nets out of the 171 million of that year and the ones of the previous years could be distributed. So this was a disaster in many countries. If you move around Africa, there is a lot of humanitarian and health emergencies. Things like conflicts, we're now seeing more and more of them in the western part of Africa and also in the eastern part of Africa. Famine is our rubber stamp in many African countries, and even things like flooding. When these calamities occur, it becomes very difficult for our weak health systems to cope with them. So for example, in 2021, people in the DRC, people in Ethiopia, Mali, Nigeria, Somalia, South Sudan, Sudan and Uganda had these kind of emergencies, and that affected their ability to manage disease, including malaria, in their countries. More recently, we have had a new mosquito known as Anopheles stephensi, which we call an invasive species. This mosquito is very good in transmitting malaria. It is from the Indian subcontinent and also from the Arabian Peninsula. It came in Africa through the Horn of Africa, and a number of African countries have been able to detect this mosquito locally, and those include Djibouti, something like 10 years ago, Ethiopia, Sudan, Somalia, Nigeria, and recently Kenya has reported this mosquito. This mosquito stays mainly in urban areas. In Kenya, for example, most of our urban setups do not have malaria, but with the coming in of this mosquito, it might be that we start seeing malaria in places where we haven't seen the disease previously. It means that we've got to find a way of knowing this mosquito better and using that knowledge, that evidence to attack that mosquito before it causes havoc within countries in Africa that are trying to eliminate malaria. So what am I saying in conclusion? If you want to eliminate malaria, you need very robust diagnostic tools. We also need to stem parasite resistance to commonly used and till today effective drugs. We need to also stem vector resistance to insecticides. But more importantly, we need to put money on the table. We need to make sure that there is money to fund control programs or elimination programs when need arises. For Anopheles stephensi, it means that we have to also use tools that will be that will prevent the further spread of these mosquito across the African continent. And of course, learning from Algeria, it's important for us to improve our healthcare systems, to do integrated vector surveillance of the vectors and the parasites. We need well-trained health workforces. We need effective vector control, universal healthcare, rapid response to outbreaks. That has been very useful in Algeria. And of course, early diagnosis and treatment for the disease. Thank you so much for listening. Back to you, Rose.
Thank you, Richard, for that keynote address. And may I request if you can pull down the slides, just so that I want to invite the panelists and request each of them to put on their videos so that the colleagues who are here can engage with them better. And I'll just start by introducing each panelist, but of course, as I do that, also confirming that they are here. I would like to introduce Dr. Fredros Okumu, if you can confirm, Dr. if you're here. Dr. Fredros Okumu is Director of Science at Ifakara Health Institute in Tanzania. He is a public health researcher and a mosquito biologist working on improved approaches for surveillance and control of vector-borne diseases. Dr. Fredros, if you're here, I hope you've put on your video. The next panelist who will be joining this conversation is Dr. Susan Imbahale. Dr. Susan is a senior lecturer at the Technical University of Kenya. She is a medical entomologist and serving at this university. She's passionate and committed to developing capacities and skills of individuals and communities through teaching and training. She has just trying to pick specific things of interest. She has her research, most of her research has focused on mosquito vectors, mainly larval source management, and some of the questions she'll be speaking to around that. And she has published widely in this area. Karibu, Dr. Susan. My next panelist is Honorable Timothy Batua, Honorable Dr. Timothy Batua. He's the chair of the Uganda Parliamentary Forum on Malaria. In Uganda, a very well-known champion for malaria in the country. Dr. Batua is a pharmacist by profession and a member of parliament. He is championing malaria efforts as chairperson of this caucus that I've just talked about. And this is a platform comprising incumbent members of parliament with intent and really focused on budgetary appropriations, legislation, and oversight to fight, to strengthen the fight against malaria in the country. He is also Shadow Minister for Health in the country. And finally, I have Mr. Shija, Joseph Shija. He's the head of Zanzibar Malaria Elimination Program. He has spent almost 2 decades in senior management roles in the Ministry of Health in Zanzibar. And before that, before he joined the elimination program in 2010, he was the coordinator for the country's affordable medicines facility focused on malaria. And so those are the panelists we have today. And of course, Richard as well, he's on board as well. Just going to check, I don't see any questions on the chat. And so I'm going to start off with just some conversation with the experts who are here and the leaders who are here around the topic of today. We know that malaria, yes, progress has been made. We are not saying no progress has been made. Progress has been made to date, but we know that this progress has also stagnated, and that's why we still see very huge numbers of deaths and of illnesses on the continent from this disease. As if that's not enough, Richard has just talked about some new threats that are going to compound this current situation. So the arrival of the Stephensa in the Horn of Africa, and I think in Nigeria as well, is going to compound this problem. And so the numbers could potentially go up, which would be disastrous for the continent. We also know that the ongoing climate change also does pose a bigger challenge for the fight against malaria. And so I'm mentioning these things just to really flag the magnitude of this challenge, and not to put our spirits down, but the fact that we really need to change the way we are working. The issue around investments is so critical, because without the money, then some of the things we're talking about here can't happen. But I'm somebody who is so passionate about malaria because I have suffered from the disease so many times. I have also come this close to dying from this disease. And that's why you might find me perhaps overly passionate, because I can't wait for a moment when malaria will be eliminated. I'll be starting with Mr. Shija Joseph. from Zanzibar. And Zanzibar is known as one of the countries that has made a lot of progress, towards malaria elimination. So, Mr. Shija, could you speak to us briefly? And I can't see you here on my panelists, but could you speak to us briefly? I'm assuming you're actually there, around the efforts, that Zanzibar is making towards malaria elimination in the country. Mr. Shija, over to you.
Yeah, thank you very much. Thank you very much for inviting me to participate in this very important talk. And I want to talk a bit on the efforts that has been made in Zanzibar, particularly towards malaria elimination. Briefly, if I take back to the history of malaria in Zanzibar, you all know that Zanzibar was among the countries that were badly hit by this disease. And the efforts to eliminate malaria began since the colonial era. We know that during those times, Zanzibar even applied to use the DDT to eliminate malaria, but those efforts were not much successful. And we saw that it was almost to elimination in the early 60s when malaria in Zanzibar was almost to be eliminated, but due to withdrawal of some interventions, the disease came up again. But major efforts started in 2000, in the year of 2000, whereby different partners, particularly the WHO rollback malaria and the Global Fund, as well as USAID, PMI, highly contributed to support Zanzibar towards malaria elimination. We see these efforts that put together the interventions, particularly the vector control or integrated vector control interventions, long-lasting net distribution, indoor residue spray that begin in early 2006, and the other interventions, especially on case management, introduction of MRDTs in 2006, and the ACTs that were introduced in 2003. Those combined interventions significantly helped Zanzibar to start significantly reducing the number of cases that were reported in the health facilities. We continued with this effort by formulating or introducing now the surveillance system. The surveillance system in Zanzibar is very robust, and it is one of the core interventions that is helped us a lot to make sure that now we investigate. First, we report the case at the health facility through a mobile phone, and we make a follow-up at household level to investigate additional cases to the other household members. This intervention, I can say, is one of the interventions that helped us to identify more cases at the community that were missing to be reported at the facility. This also continued with the case classification, and we are now able to classify the cases as local, imported, or introduced, or either induced cases. The classification of the case is one of the criteria for WHO to make sure that you classify the cases to identify the magnitude of disease, where it's coming from. And due to this classification, we have noted that we also improved our surveillance systems, particularly the database for reporting or gathering the data for malaria. That is one of the most significant things that now come to understand the number of cases per district, per region, or even per village. And we are also making much efforts to strengthen the case management. The case management is one of the intervention that involves the diagnosis and the treatment. And for diagnosis as well, we are using the MRDT as a quick device to detect malaria. It can be used everywhere by anyone who has been trained. And this also helped us to now identify more cases that were missing or were not reported before. And we have the social behavioral change communication. That is very important for us because without creating awareness to the community, even the intervention that we are conducting cannot be accepted by the community. So by creating more awareness to the community, this helped a lot for us to make sure that the people or the population of Zanzibar understands well what is malaria and how they can prevent themselves from malaria. And Zanzibar has a small population of not more than 2 million people. That's also is another potential area to take into account because we can reach at everywhere within Zanzibar. You can go within 1 hour, and if there is any kind of response, it is very easy to go to respond to a particular place. Having said that, we know that Zanzibar is at the elimination stage, and in 2016, for the first time, we introduced the use of primaquine as an antigametocide drug to tackle the mature gametocytes for the identified, or confirmed malaria cases. In that case, we have been using primaquine in combination with the ACTs. And the primaquine, is used at a low single dose. It's not the full regimen of primaquine. It's a small single dose that is given on day 1 for those who are eligible to take the primaquine. Know that pregnant women and the lactating mother and the children under 6 months are not given primaquine. But that is not bad for Zanzibar because we have noted a shift of disease trend from whereby in the earlier years, in 2000 and before 2000, we were reporting a lot of cases for under 5. But now that is not the case for Zanzibar. Currently, the more cases are reported in a young age. From 15 years to 45 years, the trend has changed. And we have noted that there are some behavioral aspects related to this that need to be, to conduct either a research or operational research to identify additional characteristics that bring to this trend to shift from the age of 15 to 45. We no longer report more cases under 5, and a good enough if I talk on the successful efforts that have produced a significant reduction of number of cases in Zanzibar, the Tanzania Demographic Health Survey conducted in 2022 also reported that Zanzibar has almost 0% prevalence malaria. But if you come to numbers, when we talk prevalence, it's difficult for Zanzibar to understand how the situation is. But we usually also refer to the numbers or number of cases. For instance, in 2021, we had only more than 6,000 cases that were confirmed and reported in our system. And this number has been reduced in 2022 to be, that were reported to be like 4,000 cases that involves all groups. And under this, since we are classifying the cases, we have noted over 80% of the cases that were reported in 2022 were imported cases, while only 20% is the local acquired cases. So you see this shift of a transmission from imported to from local to imported. You may note that Zanzibar is doing much better to minimize or to reduce the number of local acquired cases. Of course, you know, Zanzibar is an island consisting of two small islands, and the flow of population from Tanzania mainland or from other countries is huge. As you also know that Zanzibar is a tourist country, and there is a lot of people coming to Zanzibar to visit, either for business or any other social gathering. And this also brings into the situation which we are reporting now, that imported cases are more reported for more than 80% of all cases that were notified. Now this we can say is a new challenge for us now to come with the new interventions that will address the imported cases. We are currently finalizing to implement the strategic plan that was developed 5 years ago, 2018 to 2023, and it is coming to end in June this year. We have already developed a new strategic plan that will start in 2023 to 2028. And now this new strategy, the trend of age group disease pattern transmission, and the trend of importation of cases. Good enough that the deaths or mortality due to malaria in Zanzibar is very, very low, I can say. Because in 2021, only 8 deaths were reported countrywide, and were noted in 2022 almost 50% reduction in the mortality. It was reported only 4 cases. And good enough is that under all these cases that were reported as a death due to malaria, no pregnant woman and no under 5 is death that occurred among them. Zanzibar is doing, we conducted a death audit to confirm if the death is really true malaria death or not. And that also helps us to be sure that the number of deaths reported due to malaria is really true malaria death. And the more important...
So, Dr. Shija.
Yes.
Dr. Shija, you've mentioned a couple of things that I just want us to reflect on a bit more, particularly for the next speakers that I'm going to have, but I'm also going to come back to you to speak a bit on the successes. You've already mentioned some of the successes, particularly the very few cases of deaths that you're recording. I was just noting those down, but also the fact that much of your malaria is now imported into the country, which means local transmission has gone very low, which is a big success for the country. So I'm going to be coming back to you to say a bit more on the successes shortly. But I want to bring in Dr. Fred Rose to talk a bit about the feasibility of other countries, countries that have malaria that is endemic, but also countries that are not like Zanzibar. They don't have a small population. They're not islands, so you can't easily contain. I'm talking of some of the top 5 countries that Richard mentioned, the ones that are bearing the big burden of malaria on the continent. Dr. Fedros, could you speak to what is it feasible these countries will even eliminate malaria by 2030? The answer may be obvious, but also what are some of the things that will likely make them not eliminate malaria by 2030 or eliminate malaria by 2030, depending on what your answer is. Dr. Fedros.
Thank you so much, Rose. Can you hear me?
Yes, I can hear you very well. Yeah.
Excellent. First of all, I have to say it's been really nice to listen to both Richard and Shija. And I think Zanzibar is a pretty good example of what can happen when you have dedicated efforts, but also a very good example of some of the challenges associated with just being in one continent. So why this must not be a single country effort, but must be tackled like a continental effort. So when Dr. Shija was speaking, you could easily deduce that, however much they do, they probably will not get to 0 cases until the neighboring countries, and mostly until mainland Tanzania goes to 0. When you have a case where 80 plus, or a majority of your cases are imported, there is only so much you can do to get that. So I think what they can achieve is like 0 indigenous cases, 0 local transmission. And I think they have demonstrated that despite some significant difficulties, this is something that they can do. But I would like to use that example also just to demonstrate how difficult it is for countries, even small countries, to go to 0 when their neighbors have not gone to 0. So message number 1 here is that we have to tackle this as a continental effort as opposed to a national effort. Of course, majority of the effort has to be within the country, but we need a lot more of continental effort. So you asked me, can African countries eliminate malaria, and so can some of these countries that are not islands eliminate malaria? And I think that the general answer is yes. But the question is when. Okay, so yes, of course, but when? So think about countries such as South Africa. They still have some cases. It's not as many cases as others, and so you could argue that based on what has happened and what they are currently doing now, that in the next 10 years or so, they could possibly go very close to 0 or maybe even 0. Think about countries like Eswatini, not even 1,000 cases now per year. And you could argue, therefore, that maybe countries like that can go to 0 as well. Botswana, Eswatini, and all that. Cabo Verde, Richard said that they already have applied, that they have 0 cases such as that. So there are countries like that, but I think that the majority of countries, Rose, are not there yet. And that's an important message. So the second message from me is, yes, there are countries that have opportunity now to go towards 0. Some big ones, including South Africa, with a very long coastline, which is kind of, you don't have many neighbors. You have neighbors in the north, but not many. So Botswana, Eswatini, but these are the rare cases in Africa. The ones that are still close to the equatorial region, I think this is very difficult circumstances, and maybe we should not be talking about malaria, zero malaria by 2030. I think that is it's a dream, yes, but I don't think it's realistic. I think we should forget about it and maybe even replan what the target date is. So those are the answers that I can give now. I can come in later and discuss a lot further. But basically, yes, there are countries that can go to 0. Many countries will not be able to go to 0. Lastly, Rose, I know we have limited time. Lastly, when Richard was speaking, he listed examples of things that countries like Algeria have done, and also he made some suggestions of what we need to do. And here I throw back a question to you, to the audience here. Assuming that we did all those things, would we actually go to 0? Or and if we went to 0, if mainland Tanzania recorded 0 malaria, or if Uganda recorded 0 malaria today, what exactly does that mean for tomorrow? So what I'm saying here is the aim shouldn't necessarily be 0 malaria, but rather a malaria-free society on a sustainable basis. We should be looking at not just going to 0, but actually making these environments completely malaria-free for a long time, and building some resilience in those systems, building some stickiness in those systems, which is a very different question than just getting 0, because you can get 0 today, that doesn't mean 0 tomorrow. Thank you so much.
Thank you so much, Pedros, for those reflections, and even throwing back a question to us. I think it's very important for us to reflect on that. It's one thing to want to get to 0, but how do you sustain that? So you don't want to get to 0 today and then tomorrow you're back at 1,000 or 20,000. it's pointless. And I think it might be useful as I move on to the next panelist for you to think back on coming back to us in terms of, yes, we agree 2030 is probably not possible for some of these, particularly endemic countries in the equatorial region that you've talked about. But are there things these countries should be doing differently? Right. And also I see there's a question from one of the participants here asking about new tools. And I would like you to reflect about that question and maybe come back to us. It says there's some new tools like gene drive mosquitoes, which are said to have big potential. Is there anything that African countries are doing to utilize new tools to eliminate malaria? So I think something you could come back to speak to as I move to Dr. Susan. And Dr. Susan, your profile talks quite a bit about the work you've done on larval source management, which is a very well-known way of stopping prevention, and it has been used successfully in other parts of the world. So, Susan, larval source management is being used in Africa, but somehow in some of these countries, particularly the large countries that Fedros has mentioned, and which we saw in Richard's presentation, those that have very huge burdens of malaria. Why is this? What can African countries learn from elsewhere about this? First of all, I think my big question is, why is this not moving us closer to, eradication? But also, what can we learn from other parts of the world where this contributed largely to elimination, but somehow it's not getting us there in Africa? Dr. Susan.
Oh, thank you very much. I'm glad to be part of this conversation. First, allow me to just define LSM for those who may not know. Larval source management is basically the management of the water bodies. This is where the mosquitoes breed. And it basically takes care of the aquatic stages or the immature stages of mosquitoes. And there are basically 4 ways you can implement LSM. We have habitat management, habitat manipulation. All these 2, we classify them under environmental management. And then we have biological control, which is basically the use of natural enemies. Natural enemies that you introduce into the habitat and they feed on the immature mosquitoes. Then we have larviciding, and larviciding, basically we have the biological ones, for example, BTI, and we also have the chemical ones. So LSM has mainly been the main focus of control programs for many decades, especially in the US and Canada, throughout Europe, Brazil, and Singapore. And of course, also we have some other African countries which have also succeeded. And for example, the US continues to use it as a main mosquito control tool to date. And what happens is they really budget for millions of dollars are budgeted annually for LSM activities. So for us, I think in Africa, we need to include LSM as a complementary tool to be used alongside indoor residual spray and long-lasting insecticidal treated nets. I'm saying complementary because we've already made so much progress using IRS and LLINs. We seem to have stagnated. What do we need? We need another complementary tool that can help us to gain or move towards elimination. And LSM will really be helpful, especially in dealing with residual malaria transmission. Realize that IRS and LLINs only targets the indoor resting mosquitoes. What is happening to the ones that are biting us when we are outside? That is why I'm saying LSM, we need to consider and include it as a complementary tool. We need to budget for LSM activities. Initially, it may be very expensive, but once, for example, you eliminate a habitat, then you'll have no more mosquitoes breeding and therefore you'll have no more malaria. However, if a strategy like larviciding has to be adopted, then we need an annual budget that will put that into consideration. We also realize that majority of breeding habitats in the African setting are man-made. And this has been identified by so many researchers and research that has been done in the continent. So what we need to do is we need to educate the public they need to know, majority of them actually, and the findings of lots of these studies is the communities do not understand how the activities contribute towards malaria. So we need to educate. Public education is very important. We increase awareness and involve communities in the control activities. In terms of mapping, we need to invest in mapping tools, for example, the geographical positioning system, geographical information systems, and remotely sensed data. This will increase our operational efficiency and mosquito surveillance and control. And this, of course, has been adopted by mainly the countries which are doing so well with this strategy. And of course, we know very well that mapping habitats by pencil and paper is very laborious. So we need to adapt the new technologies. Again, collaboration between ministries is important. Ministry of Health alone will not manage. We need to collaborate. Ministry of Health needs to collaborate with other ministries, other sectors, and research institutions so that we leverage on the resources and the personnel. And larvicides basically have already been developed. We don't have basically to go back to studying and coming up with other innovations. Larvicides are available, they've been developed, and research on non-target organisms has already been done. So therefore, all we need is if we prioritize it and include it as a complementary tool, we actually have the larvicides to use. And basically then LSM is a well-established strategy. Realize that this is what was used to eliminate malaria way before in the 1940s and earlier. This is the strategy that many countries use to achieve malaria elimination. It can easily be adopted through the National Malaria Control Programs, which is basically what is common in our African setting. And all we need to do is we need to take into account the mosquito behavior and adaptability. You realize that we've stagnated, and this is because the mosquitoes have also adjusted, they've adapted. Now, they basically bite us from outside, not indoors anymore, because you have a bed net and because you've sprayed the houses. So we need to take into consideration the mosquito behavior and adaptability. Thank you.
Dr. Susan, you just reminded me, every time I think about the mosquito, I think it's the most clever animal, clever than human beings, because clearly, so far in Africa, the mosquito has won the malaria war. Exactly. That's what I keep reminding myself, and I've struggled to understand why we've let such a tiny animal win the malaria war and take away so many lives.
It keeps adjusting and adapting to the technologies or the tools that we apply. So we also need to be either be quicker in adapting new strategies, or we alternate basically. And that is one of the strategies in controlling the insecticide resistance. We need to be alternating.
The mosquito clearly thinks ahead of us, right? Anyway,
exactly.
But one thing you've said, and I was gonna go on to Honorable Batua, but I just want to follow up one thing, if you can maybe speak to it quickly. Why is larval source management not one of one of the complementary tools in national malaria programs, especially that this has been shown to work? Is it an issue of budget? Is this an issue of what's going on there?
So this is what I can say with regards to that. Ideally, previously, we know very well, LSM was the main control strategy, and many countries basically showed success. However, the arrival and adoption of indoor residual spraying, especially using the DDT in the 1950s to 1969, this led to a shift in what was happening. So DDT, by using DDT in RRS, many countries eliminated malaria, and therefore this shifted the focus of the entomologists and scientists and even donors at that time to now focus on IRS. And ideally, that is what has happened ever since. And then in the 1980s, efforts again were geared towards developing insecticide-resistant, insecticide-treated bed nets. We shifted now, IRS, now we added the ITNs and now LLINs. So that was the shift, and we basically, the main focus now went towards development, the focus, research focus and donor focus was on attacking vectors indoors with insecticides, either by using IRS or the ITNs and now LLINs. So that is how we basically excluded or forgot about the LSM.
Which beats the logic. And here I'm speaking as an African who has suffered from malaria, because how would we shift from dealing with the source of the mosquitoes to now wait for them to come in our houses and then we start attacking them there and then hope we can eliminate malaria? But I'm speaking now as an African who has suffered from this disease, and some of these conversations I have just sometimes beat the logic in terms of how we have shifted over time and how we are managing this disease. I think that the points the speakers here, the experts here bringing out is really a mix of tools, right? Not a shift. We shouldn't be shifting from one to the other, but rather a mix of different tools that would work maybe even in different contexts to move us closer to eradication. But I want now to go to Honorable Batua. Honorable Batua, I hope you are here. Unfortunately,
yes. I'm here,
Fantastic.
Rose. Let me hope you can hear me.
I can hear you and I can see you. I wasn't seeing you before, but you know, this technology. Yeah, but thank you for joining us. So I want you to speak from a different angle in terms of the role of political leaders. And I know that you're leading this caucus in Uganda. Could you speak to what is the vision? How do you see this caucus contributing to Uganda's efforts to elimination? Because Uganda is one of the top 5 countries. I'm just thinking of Richard's list. That is among the top 5 countries accounting for a really big burden of this disease on the continent. So how is the caucus contributing to Uganda's efforts, particularly efforts towards elimination of this disease? Honorable, please take it away.
Yeah, thank you very much, Rose. I'm glad to join the panelists we are with here. And I'm glad that I'm coming in at the extreme last, I guess, after gathering the minds of the various panelists in there. Definitely from the perspective of a politician, by nature, for us, we discuss anything, be it in what specialty. The moment you put it in there, we start debating it and we make a decision on it. So for the decision to be of quality, it's normally good if we've been empowered by way of some knowledge on a particular topic. But for malaria, thankfully, we identified a group of ourselves who are passionate about the disease, and we formed a forum called Uganda Parliamentary Forum on Malaria. These are members of parliament who are incumbent, who are still in parliament, and the purpose is for us to use our mandate. That is, the constitution gives us a mandate to do budgetary appropriations, to use our mandate like legislating to influence policy and oversight, to really see that we drive the fight against malaria. So we work with development partners and other stakeholders and support them where they feel they need some legislation or some policy support. So that's how we are coming in as a forum on malaria. But of course, we don't take the decisions on ourselves. We are very few. The Ugandan parliament is about 529 MPs. So we have the burden of influencing the other parliamentarians to believe in what we see and join us in taking a decision that is in line with what we agree with. So at the moment, we are in the budget process, and we pick all this from a single point, that most of the challenges in malaria, like for Uganda's case, are arising from limited financing. You can really see very good interventions, just as the previous speakers have said. They've mentioned IRS, they've mentioned the chemo preventions, the insecticide-treated mosquito nets, but all these interventions will be implemented within a small geographical area. You know, they've not covered the entire country. You will not see a single home where every occupant has a mosquito net. You know, once it's a program, they may decide to give mothers who are pregnant. They may decide to give children who are under 5. So those you can see using mosquito nets, but the other house occupants, they will not be using mosquito nets. So these get the parasites, they get sick, they get treated, they become hosts of the parasites, and these can transmit them. When it comes to larviciding, this has been done in very small areas of the country. And I think, from the previous interaction we had with Ministry of Health, the coverage was as small as 1%. That time it was implemented in Kigezi sub-region, which had the least prevalence of mosquitoes, sort of malaria. And we questioned why you implement an intervention, a malaria intervention, in an area that has the least prevalence. And they informed us that they wanted to protect the areas, those areas where success is already noticed, so that those gains are not lost. Then they can advance to other areas. But again, the budget at the time could only support it in a small area. So they wanted an area where it would make an impact. So all that stems from financing. So we have a burden to really improve this. And I can inform you that at the moment it is very challenging, knowing very well that even the budget to the healthcare sector has been reduced by a certain percentage. So really advocating for more financing to these sectors needs us to have a lot of knowledge, like the one I've just received here while Professor Richard was speaking. The entomologist who also spoke a lot of good talking points that can really convince colleagues in Parliament to break the ceiling and get more money into this, into financing Ministry of Health specifically for mosquito. That aside, within that limitation, we feel we can do something. We are not yet happy as parliamentarians with the level of oversight we've done on the little resources that are being channeled into the fight. And we think we should do more. We are in the process of identifying some training to empower us to know exactly the areas we should look at to ensure that malaria and the finances geared to it are well watched over. So we need to identify those areas so that we do a good work. There is a motion that I'm intending to put on the floor of Parliament. It was supposed to be last week, but we had activities of the budget, and it could be a week from now, but it will definitely be there. And in that motion on malaria, in commemoration of the World Malaria Day, which is today, happy World Malaria Day to all of you. So in that motion, among other things, we want to identify a local revenue that is day street parking. In Uganda, when you drive on our roads and you park a car, especially in the cities or towns, you charge the fee for that street parking space. So we wanted at least a percentage of that locally collected revenue to be directed towards fights against malaria, and government can complement that figure. But the local governments, district governments should have an envelope or a fund from which some of these interventions can be managed. So that is still a matter of the motion that we shall speak to, and where the House finds it workable, we shall pass it as a decision, and then it will be implemented. But we feel like there should be some local initiatives that should steward the fights against malaria, and it will be against those that we can get extra funding to boost the fight. But this is something we are really thinking of. And talking points like the ones I've gathered here, knowing that there are some countries that have actually eliminated malaria, and there are those on the path of eliminating malaria. I've appreciated the way Zanzibar has really handled this fight. And we relate because in Uganda, the people at the forefront are the medical doctors. When I was in America, where they've also eliminated malaria, I discovered it was the entomologists. And of course, entomologists were, moving along the journey of larva source management. And I was very convinced that larva source management would help us eliminate malaria at the quickest, because what I noticed is that when they mapped out our country, the burdened regions are those ones with actually wetlands and water sources. Then interventions, we are using small tools. We are using these backpacks for agriculture use. Now, you can't do larviciding of a swamp, a very big swamp covering 4 or 5 villages using this. So while in America, I saw drones, I saw fixed wing aircrafts being used, I saw helicopters, and we have those things here. We have them in our teaching schools. We can repurpose a few of them, remove seats and put tanks. That's what I've always told my legislators. And then we spray, but they are challenged with the safety. How safe is it spraying these things from the air such that humans consume and everybody consumes before they reach the water sources? So these are topics that I've really not appreciated. I've appreciated the concept, but on grounds of safety, I need more interactions that I keep championing that. But I really believe going for the large sources first will drastically bring down the disease, because the population of these mosquitoes will, greatly lower. What we are doing, we are going for small sources, broken utensils, which are within your homestead and holding water after a downpour, rainfall. Please drain that. Then there's people with those small equipments on their back, they pour us their larvicides in, such things. But I have visited these villages with parliamentarians trying to get the assessment and impact of malaria on the vulnerable communities. And we did this throughout the day, and in the evening, I can literally tell you, we were bitten by mosquitoes, and it was really terrible because we were seated outside, and you would really see that these are coming from the bushes, these are coming from the wetlands, actually the wetlands that are around those areas. These areas are rice growing. They have huge rice growing fields, extending in terms of acres, hundreds of acres. So I believe our magic bullet to complement what we are doing will come from area spraying maybe area spraying by way of larviciding. But being on a panel of other experts, I've seen the entomologists, we can get guided in that. Thank you very much.
Not commendable the efforts of the Uganda Parliament, but also speaking to the partnerships that I think it's Dr. Susan who talked about, stronger partnerships among different actors, so members of parliament, people in the academia, people in ministries of health, communities, of course. We are the ones who bear the disease, the burden of the disease. So those partnerships would be critical. And I'd like that you ask some questions here. I see that we have about 12 minutes. I don't know how time flies, but about 12 minutes to wrap up this. And so, be very strategic, because I'm going to give each one of you about 2 minutes to just give your final shot. And there are several questions on the chart. And so as you speak, could you please speak to some of the questions? I'm looking at them as well. Some of these questions, they apply to different people, but I want to start with Susan, so that you speak directly to the question that Honorable Batua has asked. Dr. Susan, Honorable Batua has talked about issues of safety around aerial spraying, and he's also talked about, I think it's more of a comment though, wondering why we are not targeting the wetlands and the irrigation schemes maybe, but the wetlands, the large rice growing areas, why we're not targeting that. But I think his big question is, are there safety issues? Because that's one of the things I think communities would start asking if we are doing aerial spraying in large scale. They might start wondering and maybe being concerned about safety. So if you can speak about the issue of safety, but also give your parting shot, I'll give you 2 minutes, and then I'll be going to the other panelists like that as we wrap up. So the other panelists, you have opportunity to look at charts, speak to area of interest. I know I had flagged specific issues to follow up with each one of you, but I've just realized I have run out of time. So please give us your parting shot and speak to questions on the chat. And I see more questions actually coming up there, so I'll keep my eye there as well. But Dr. Susan, please, if just a minute or two to speak to the issue of safety on LSM. Yeah, thank you.
Thank you very much. And thank you for the concern you've raised. Ideally, all the insecticides and larvicides that have been approved have gone through all the stages that are required. And one of them is, of course, doing experiments or research on the non-target organisms, and that also includes finding out if the larvicide or insecticide would be harmful to humans. So before it is approved by WHO, all those, they must get results from various laboratories around the world which carry out those investigations. So ideally, before any of it is approved to be used, it has already satisfied the requirements of WPES. So that should not worry you when it has already been approved, and there is a list of all the insecticides and larvicides that have been approved by WPES. That is what you need to select from. You need to select an insecticide or larvicide from the list because it has already achieved or tested, gone through all the toxicity tests and has been approved. So that is what I can say on that. You should not be worried if it is on the WPES list. My parting shot as we continue with the dialogue on malaria elimination, LSM needs to be considered as a complementary tool to help tackle the challenges faced by insecticide resistance and the issue of invasive species. We've already heard about Anopheles stephensi. And in line, this will be in line with the WHO Global Vector Control Response Strategy for 2017-2030, that is basically calling on all nations to scale up on integration of tools and approaches. So that is what I'll say. Thank you.
Thank you so much, Dr. Susan. Coming to Mr. Shija, Joseph, if you can give us your parting shot in a minute or two. As you do that, maybe just speak briefly to how Zanzibar may have used larviciding, if at all, in your elimination efforts. Thank you. You are muted.
Yeah, thank you very much. What I can say, Zanzibar, we have not much applied the larviciding intervention. We are doing it a very small scale, and this is mostly supported by the government. You know, partners are not much supporting this intervention, and I agree with Dr. Susan that if we need to eliminate malaria, we have to go to the roots of the cause of this disease. And the larviciding is applied, but it is applied ad hocly in small scale, and we haven't seen the impact of that. So we can say that we cannot say is working or not working. Yeah, thank you.
Okay, thank you, Mr. Sija. Sorry, mixing up your name. So sorry about that.
No
sorry
problem.
about that, but thank you.
Yeah.
Sorry, it's because of where I come from. We struggled with some of this tests. Dr. Fred Rose, your parting shot, and if you can speak a bit to the question of around new tools, if there's something to say around there, but also your parting shot around how do we move faster towards elimination on the continent. Thanks.
Yes. So first of all, on the new tools, I think someone mentioned GeneDrive. My thoughts on GeneDrive are that number one, we have a number of new tools currently being developed. You have vaccines that are coming into play right now. You have new medicines. You have new insecticide classes. You have monoclonal antibodies. You have a number of these new tools. Now, many of those require that you also have in parallel a fairly strong health system infrastructure to deliver them. The reason I think that GeneDrives are special is that they are probably one of the only ones of the new tools that could perform fairly well, even in the absence of a strong health system infrastructure. Even in the absence of parallel socioeconomic development, which, by the way, we also need to sustain low levels of malaria. So GeneDrives are special in that case, that if they are successful, if they are demonstrated to be successful, they could spread themselves, they could remain effective, without necessarily having to also in parallel invest in strong health systems. Now, of course, this is not to say that we do not need strong health systems. This is just to recognize that malaria is mostly a problem of very poor communities. And in such communities, often we do not have strong enough health systems, which are necessary to sustain zero. And the gene drives, in my opinion, are the only tool in that package right now that could do that job. Of course, if we had like a 95% efficacious malaria vaccine that lasts 5 years or 10, that would probably also do as good a job. But at the moment, unfortunately, the malaria vaccine candidates we have do not reach that threshold. My parting shots. What is really our interest here? Is it to go to zero to celebrate a milestone? Or is it really to keep our countries disease-free? Professor Richard Mkabana was my university professor many years ago. And I remember, I don't know if he remembers, but I remember one thing he told me, that you know what, Fredos, the difference between us and our Western colleagues is that their interest is to keep their countries disease-free. Our interest is to eliminate the disease. And you see, these are two different things. And I am more of what Richard was saying, that you see, we should be looking at what we need to do without necessarily isolating a single disease, malaria, TB, or what we need to do broadly as a country to keep our communities disease-free. And then you quickly realize that malaria is not just a problem of the health system. That you need to be working on the environment as well. You need to be working on improved housing. You need to be working on the health system. You need to be making sure families with just $1 are not choosing whether they should pay for malaria medicine or buy food. So it's a more comprehensive thing. And I think parliamentarians, when you discuss this, you must not discuss it as a malaria, as an individual disease case, but rather as a comprehensive societal issue that needs to be tackled more broadly. Thank you guys so much. I think we can eventually eliminate malaria. I think it's a very difficult thing. I think that will not do it by 2030. I don't think that the current strategies are heading there. I think we are on the wrong path. I think we like to celebrate useless games, if you like. We like to celebrate small things and pat our sense of the back, but we are really not going there. We need to really think broadly about which direction we want to go and refine and go towards that. Back to you. Thank you so much.
Reality check. Wow, thanks, Dr. Fredros. Richard, your parting shot, and then I'll be finishing with Honorable Batua, and then I just wrap up some key points moving forward, and of course flag our next webinar. Richard.
Thank you so much, Rose. I want to underscore the fact that Africa is extremely heterogeneous, and there's no single tool for controlling malaria that can be used across the continent. Most of the tools we have for malaria control right now are based on people that are sleeping, like you're in the house and you're asleep. But as life becomes harder, people are doing many things at the time when others are sleeping. So they need very different tools to control this disease. I think we have to get our interest very high on this problem and use any single tool that we have out there to control the disease. Thank you.
Thank you. Thank you so much, Richard. Also reminding us that, yeah, we are one continent, but very different. So the integration of tools remains very, very critical. Honorable Batua, your final parting shot.
Yeah, most importantly, we need a common approach, as one of the panelists really mentioned. Equally important, I believe we should have a common impression of stewardship. In some governments, I see medical doctors leading us. And when they lead us, they are biased with case management. They are biased with handling the disease. In other countries where you see entomologists giving the lead, you see vector control coming out prominently. So if there is to be a common result, we should have a seemingly common, stewardship. The other one is about integration. When you look at what has been done in my country, the impression you get when you cook little food and the guests turn out so many, and you're like, maybe if it's posho and beans, ugali na maragwe, is it maragwe? Okay. And then when you serve, for the first 5, you serve the food, the posho. Then from 6 onwards, you say also you can't get the posture, but get the beans. Then the others, you say, please wait. You know, integration, that's how it has been done, integrating interventions. In one corner of the country, you find it is mosquito nets being distributed. In the other, you find it's chemo prevention. In one, it's IRS. The other side, larviciding. They're not done in the same locality. They're just scattered so that everybody gets something. So clarification should really come out clearly on how integration should be done and how we can use limited resources. Finances are few, a little everywhere, it's a limit. But how do we act? How do we handle a situation where your finances are really scarce? Last but not least is on vector management. That I believe we should go for this larviciding at source management. And then, of course, I believe in aerial spraying for what I've been empowered to see, that aerial spraying is very effective. But what I know with vector management, it's an ongoing process. You can't do it once and that's it. You have to keep reducing the threshold of these mosquitoes. And by doing it, you're not only eliminating malaria, but mosquitoes also transmit other diseases, yellow fever, dengue, Zika. So you are as well putting your foot in another area that you've not yet felt, but you would otherwise feel if the disease outbreak exists. But now that the fight against mosquito is ongoing, and aware that mosquitoes are becoming resistant to the existing methods that we are using, it's important that we invest money in innovations, in tools that will help us for the future. Of course, right now we have hope in whoever is having effort in gene drive, whoever is driving it so that it yields. At the moment, it is still in research. So we have hope in such tools. And to widen that area of knowledge, we need to support it with funding, but also most importantly, the legal framework that will enable a very good environment for such innovations. So in Uganda, we are working on the biosafety law. Of course, it has come up with challenges, but we need to create a very good environment for this kind of research. Thank you very much.
Thank you very much, Honorable Batua. You actually wrapped it up for me, but I'll say just a couple of things as we wrap up. The experts here and leaders here have said it all. What stands out for me is a holistic effort that is owned by African countries, it's owned by our governments, it's owned by communities, because without that leadership and ownership, then we are likely to face the challenges that Dr. Susan was talking about, where there's a shift from one tool to the other. We are shifting from one tool that is known to be more effective to another that is not known to be as effective as the older one. And there's no clear justification of why we are shifting. And yet, if we own this, program, this effort on malaria as communities, as governments, we can make better decisions in terms of looking at if we are shifting from one tool, where are we shifting from this to the other one, and clearly, so the whole issue of ownership and leadership is critical, and it has been failing. I mean, some of you have talked about the issue of ad hoc efforts here and there. That is part of the challenge we have if there isn't good ownership and leadership by African communities and African governments. And that would, of course, also come with funding. So funding has always, as Honorable Batua has said, always remains, a big challenge. We are not putting in the monies to even implement the level source management we've said at large scale. And that is the only way it could be meaningful in our countries. But you're also not putting in money to develop new tools, And so without such investments, then we remain dependent on others to put in the money. And that's part of the reason why we are where we are with this malaria issue. There's, of course, I think an important issue around integration of tools that has been driven home. I don't even need to say more. It's not one tool. It's an integration of a wide range of tools, because some of these will work well in different contexts or are suitable for various contexts, but they also complement each other. The mosquito net alone, we have seen for many years, it's not going to eliminate malaria. It's great, but it's not going to eliminate malaria. But also, when I talk about integration of tools, I think the important issue there is around partnerships. what partnerships do we need to be ensuring that we strengthen? I like that we have Honorable Batua here speaking to, we have colleagues here from government, we have colleagues here from academia. Those partnerships need to be really strong because Honorable Batua, you sit in parliament, you determine budgets, and yet you need all the knowledge here, like you've said, to be able to debate and make the case of why we need more money for malaria. So strengthening those partnerships is so critical so that we are not as academics, talking to each other, or as people in the Ministry of Health talking to ourselves, but that we are working in ways that we are speaking to each other and able to strengthen each other's efforts, because malaria seems like an elephant on the continent. And so each one of us has some work to do on that big elephant if we are going to bring it down and move closer to having a disease-free continent, like what Dr. Fredros has talked about. And so I really want to thank you, each one of you, for sparing your time to speak with us. Very enlightening conversations here. We know that the challenge remains. And what these kinds of conversation are trying to do is just to ensure that as Africans, we are driving these conversations. But even as we drive the conversations, we are also doing our part, in getting the whole fight against malaria moving forward and progressing. I want to be at a point in the next decades to talk about us having won the malaria war, and not the reality right now that the mosquito has won the malaria war, as is the case currently. So I want to thank you very much. I want to invite you for our next set of webinars. I don't know if you want to flag them up on the screen, but we have a series of webinars coming up. As I noted at the start, this is the first one in a series of about, I think there are several webinars coming every other 2 weeks, and each of them focused on the journey towards elimination. And I think we want to maybe talk more about Dr. Fredros' terms in terms of the journey towards a malaria-free Africa, and not just elimination. So Adudo, over to you if you want to flag the other webinars that we have coming up, just for our colleagues here to have a sense of what they are. But I want to thank everyone so much. And yeah, back to you, Adudo. Thank you.
Okay, thank you, everybody. We have 4 more webinars coming up. I will put this up on screen right now. So we just had the first one. The next one, we would delve deeper into the threats to eliminating malaria in Africa. We've already touched on that with the invasive species, climate change, resistance. We'll go into that. The third webinar we've also talked about that. How do we ensure investments and sustainable financing to move us closer to elimination? And as Dr. Fredros already really touched on, emerging health technologies, talk about the gene drives, the vaccines, monoclonal antibodies. And finally, we'll end with really research and capacity in Africa to help us get into, I would say, no longer zero malaria, but a malaria-free society. So strong, resilient health systems. So I thank you all for coming, and the next webinars really would go more deeply into these topics that we've just scratched the surface on. And thank you so much for coming, and we hope to see you in the next webinar.
Yeah, just noting that we'll be sharing the slides that Richard used at the start of the webinar. We'll also share the recording of this webinar once it's available in the next day or so. Again, thank you so much for joining us, and we hope we'll have another conversation in the next 2 weeks. Thank you so much, and have a good afternoon or morning wherever you are. Bye.
Thank you.
Let me mention there's a feedback form on the chat that you should fill up.